Our admission medication reconciliation RPIW. We have several team members here in the room who will be presenting different sections of the report out. We had a very productive week here, and I can say as a co-lead of our MedRec committee, along with Anthony Biondo, that this week has really exceeded all of our expectations. We want to definitely express my thanks to everybody who spent the time here for the week in the room with all their energy and dedication of medication safety, and especially our leaders, who I will mention. Medication reconciliation, or MedRec, has important safety implications and is one of our national patient safety goals. And important for all of us is that it's something that TJC cares a lot about. It also has implications to hospital length of stay, readmission rates, and importantly, our inaccurate medication lists are a very visible sign to our patients that our processes may not be as tight as they should be. And so it has direct consequences in terms of the trust that our patients have in our health system. So medication reconciliation hits a lot of different parts of our organization, but we, for this RPIW, are focusing our efforts on admission medication reconciliation.
Hello, Eric Lundeen, Quality of Patient Safety. To build on Rob's comments on the why for this work, and particularly why we're here today, thank you for reminding me that, I want to give us a little background on where really this work originated from, which takes us back to the readmission 3P back in February, when we really looked at the driving force of how we can be able to reduce our 30-day unplanned readmissions and reimagine the transitions of care for our patients. And what came out of that event in looking at root causes is one of them that was identified is a common contributor to these unplanned readmissions pertaining to medication accuracy, adherence, and management. And this actually became one of the 12 projects out of the 3P. Before this particular RPIW, when looking at the transitions of care, we decided the right place to start is really looking at it from the admission point or of entry for our patients, and really ensuring that medication is accurate, with the idea being that when it's accurate admission, the probability is higher that it'll be more accurate at discharge, and then when the patient goes back into the community. And so with that, there were 4 primary objectives that this RPIW focused on, and really being able to design an effective and efficient processes for medication reconciliation, as well as clarification of who is doing what, as well as transparency, so we can really be able to see what has been done throughout that process. And to also be able to empower and incorporate our patients into making sure that our medications are accurate.
Hi, I'm Brian Clay from Hospital Medicine, and the first step in improving any process is defining the current state. What you see here is our process map for how we do admission medication reconciliation today. You can see that it's not simple. It's complex and has a lot of steps. And this has led to some confusion on the overall workflow, both in terms of who is supposed to do what, when, and what everybody's responsibility is, as well as how do you know what's been done already? So there's a lack of awareness of what the standard work is. There's some redundancy in the work and a lot of rework that occurs because of this. And we only have limited resources that are dedicated to conducting what's called a best possible medication history. We have one pharmacy technician who is excellent at doing this, but there's only one of her. And patient experience can be negatively impacted by this. So we have gathered multiple stakeholders and participants in this process into this RPIW this week: physicians, nurses, pharmacy, folks who work in inpatient, outpatient, pre-op, and so on, to really get at the heart of our improvement opportunities.
Hi, I'm John Bell from Hospital Medicine. So after looking at our current state, the next thing we did is we went on took a virtual Gemba of looking at the different EPIC workflows for taking a medication history and reconciliation. And so what we determined is that there were lots of variation amongst these workflows, amongst the different roles. And on the 4th day of our RPIW, we took a second virtual Gemba where we looked at the e-check-in process with the help of Kyle Ficklin-Badaloni, and looked at what we are doing now and how we're engaging patients in this process, and how we might change this in the future. Finally, as part of our 30-day goals, we're looking to figure out determine the feasibility of the workflow changes we want to make to these workflows, as well as scoping the project with IF.
Hello, my name is Sarah Couch. I'm a nurse practitioner with the trauma team. I'm here to talk about the voice of the patient. We were fortunate we kicked off the week with a story from our sponsor, and we had stories to share within the group throughout the week of our personal experiences as well. The Patient and Family Advisory Council supported us in participation in our RPIW project. Elena, a patient, was kind enough to share her experience on both her admission and discharge medication experience. She felt that having the confidence of a dedicated pharmacist on her team helped with the verification of her medications. Overall, we learned that patients are surprised that our computer systems are not connected with retail pharmacies. And this patient helped us to design our future state plan as well.
Hi everyone, I'm Trina from pharmacy. So throughout this week, we also learned some different tools within the lean process to help us not to jump to conclusions or solutions for our process. We had idea forms that you can see in the middle of the slide that propelled our thoughts because they were readily available at our desk, so we can jot down at any point in time. We also learned about root cause analysis, and everybody may know about the fishbone diagram, and there is a fishbone diagram under all those Post-its, but we had an explosion of ideas and contributors to the root cause. And then we learned about standard work and how best to approach standard work so that you can see the picture of the pigs, or they were variable until we were provided with diagrams on how to draw what our customer was looking for. So then leveraging all these different lean tools, and you'll hear about the different factors that came out from the next few presenters.
Hi, Bruce Ball from the EPIC team. And across the week, we took, there's a piece of tape over it. You want that one? We took the information we gleaned from the current state process and all the ideas that were presented to craft our future state vision. One of the key principles of that was to develop standard work and to reduce rework. Inside of that, we want to focus on the best possible medication history, a process that pharmacy is currently doing that we want to expand, and also to clearly define the roles for medication history gathering. We want to reduce some of our unutilized talent, mostly this focus around engaging patients in the process where they're able to get them to contribute to the home medication list. Throughout the process, it was clear that there was a lot of confusion as to who had done what, when the last medication review was done. So we want to really focus on creating better status visibility within our systems, so providers know what's been done and when the last medication history was taken. We want to also ensure that we have a process that patients can trust. We're looking to leverage EPIC, the tools within there to facilitate this process. And lastly, we know we need to focus on our measurements so to be able to define our progress and our success. And we're looking at both quantitative and qualitative measures for that.
Hi, I'm Anthony Biondo from the pharmacy department. And for that measurement plan, our key performance outcome metrics will be looking at the accuracy of those medication lists after the patients have been admitted to the hospital. We do that two ways. One is via leapfrog reporting, where we compare ourselves to other hospitals. We hope to improve to at least the best quartile of nationwide hospitals for leapfrog. We also have a new accuracy metric that we've developed just for this RPIW that looks at the accuracy of those lists. So we're hoping to reduce our error rates, at least in terms of medications missed during med histories, by 50%. And we'll look to see if we meet and sustain those goals in the year ahead. We also have some process metrics. A couple of those are designed around looking for compliance with our UCSD HP for the expectation that histories and reconciliations are completed within 24 hours. We also have a goal to increase the percent of patients that have a pharmacy best possible medication history completed during their hospital stay in alignment with the Senate bill required by the state of California. Thanks.
Hello, Lindsay Holt, peri-anesthesia education. So medication reconciliation touches almost all of our team members, as well as patients, families, and their caregivers. Each work group will be tasked to develop strategies to communicate updates and changes to practice with their prospective stakeholders. Examples of the communication include disseminating the progress of this RPIW with Medication Reconciliation Committee, revising education and tip sheets, implementing pilots to trial future state workflows, some of which are going to be starting in the next 30 days. Also, we will be collecting data related to medications from current patient surveys, previously collected NRC patient surveys, and through partnering with PFAC to speak directly with patients.
I'm Nicole Goldhaber from General Surgery and Peri-Op Quality Improvement Informatics. And in order to affect change on our measurements and guide our communication plan, we split into these 4 groups that Lindsay mentioned based on prominent themes that arose from our cause and effect fishbone diagram and contributor decision matrix. The first group focused on best possible medication history practices to develop standard work for a highly reliable medication history based on an awesome example of our singular dedicated pharmacy tech. The next group looked at medication history milestone visibility to provide transparency across provider and team members through multiple tools spread across staff workflows. The next group looked at standard work and process measurements to build standard work for each role along the way and leverage Epic flags and build to do this. And last, but certainly not least, our group focused on patient, family, caregiver engagement to gather direct patient feedback and improve pre-appointment preparation with each check-in.
Hi, I'm Susie Guidi with Provider Education. As you can see from our parking lot image, we have many sticky notes that identified several important issues that will be useful in other areas of medication reconciliation, such as ambulatory and discharge education. Gemba showed us that the information is displayed in multiple ways in our current state, and there is no one single way to look at MedRec and Epic. We had a realization that there's frustration in some areas. We didn't know until we all got together in the same room because we were all working in silos. We agreed the situation is not hopeless. There are several tools that are being used, but not to their full potential, so we can educate people about them and how to use them. We thought it was creative of us to think about involving the patient in the process early on, and we're really excited to engage with Epic with some ideas that will help everyone.
Hello, my name is Scott Ogan. I'm an ambulatory medicine physician and clinical informatics fellow. I'm going to talk a bit about our team experience throughout the week. So we came together to discuss kind of the whole experience on day 4 and some big takeaways that we thought were really important for us. One of the big ones was recognizing Kara's work within the BPMH. Very lucky to have her as an asset during this process to learn things that are going well, things we can improve, pieces to optimize that process. The RPIW week was accelerated, did accelerate this work more than a monthly committee could actually accomplish. So that was a huge step forward for that. There was a large amount of energy from the team regarding medication lists and the MedRec process, as it was a multidisciplinary team. So everybody can kind of learn their pieces, and everybody does touch this process. So everyone had a lot of great ideas and work with this. The focused attention of that group within the same room did benefit or will benefit the workflow in the long run. We're very glad that this process could be in person, as Zoom would not work as well as this did. We looked at a lot of the creative ways to use Epic tools, and we're excited to put those in development in the future within the limits. The different perspectives were incredibly useful as well, and networking across those different departments built positive culture and trust to get for collegiality, the things that Zoom would also not help with. We largely appreciated the patient participation, gave us the opportunity to ask questions and learn things that we wouldn't necessarily think of as we're so used to being on the other end of the EHR. We want to thank everyone involved in this process, our patient, Elena Javier, help us with patient empowerment, which is so important. Our sponsor, Margarita Baggett, who this would not be possible without. The home team, who continues to serve our patients. The RPIW advisors, Lillian Chan, Katie Metters, Michael Neese, Eilert Ruppen Pham, Dr. Allison Krishak, Dr. Brett Meyer, Dr. Vashel Tolia. The support and data collection teams, Alan Tran, Dean Pham, Kyle Ficklin-Badaloni, Perioperative Services, Shobha Kolan, APC Clinic, Marcia Jackson, and then last but not least, everyone who addresses MedRec history every single time in the past and who will adapt in the future with this as well.